Hi, my name is Roberto Lopez-Rosado. I'm a physical therapist as well as a health services and outcomes researcher. And in this video, I'm going to talk briefly about healthcare disparities and physical therapy. But first, we need to define what a health outcome is. A health outcome is a measurable change in health status that typically results from something a clinician would do, like an intervention or a treatment. Examples of health outcomes in PT practice may include walking speed for pain reduction levels, functional mobility, balance ability, and risk for falls assessments. We know that clinical care helps to maintain overall health in individuals, but there are other factors that contribute significantly to the development of health disparities, and they are called social determinants or factors of health. A definition of SDOHs would include the conditions in the environments where we, the people, are born, live, learn, work, play, worship, and age. And all of these factors have a tremendous impact on our overall health. And it will determine largely our quality of life as well. Social determinants of health are typically divided in five domains: education, access, and quality, healthcare, access and quality, neighborhood and built physical environment, social and community context, and lastly, the economic stability domain. Out of those three is the education, economic stability, and neighborhood and built environment, the ones that are critically more impactful in our overall health. So it doesn't come as a surprise that medical and clinical care only account for 10 to 20% of a person's health, depending on which resource you cite. A health inequality occurs when there's a difference in distribution of health status and achievement of health outcomes among specific groups due to genetic or other factors that cannot be prevented or modified. In this example of health inequalities, we're taking a look at stroke mortality by age and sex. In this graph, women are depicted in red and men in blue. Ages of participants are lower towards the left and higher on the right. So younger on the left and older on the right. Um, and when we see what is actually being measured, which is the number of deaths by stroke, as the sample of participants age or get up there in terms of age, we see that the number of deaths go up. And this is just a mere function of age, right? Older people are more likely to die. Um, when it comes to sex comparisons, though, if we take a look at the graph, we see that men have a higher number of deaths, and then somewhere in the 70s, it flipped, and it is women that show a higher number of deaths. But that's only because women have a longer lifespan. So these things are these effects of age are non-modifiable, and in this context, sex isn't either. What a health inequity or disparity is, well, we're going to consider those the same, is a specific type of health inequality that denotes an unjust difference in health status. So, in this context, health inequities are systematic differences in health that can be avoided by reasonable means. In this particular study, published in 2023, um, we explore the racial and ethnic disparities in physical therapy utilization after a total knee replacement surgery. And I'm citing this as an example of health disparities in PT. In this graph, what you're looking at is the distribution of race and ethnicity of participants in the study. And you can see that the great majority of them, 91%, were white patients. When I compare this to the US Census from the year prior to the study, 2022, um, I found out that the composition of white individuals in the U.S. at that age at that time was 59%. So there's um, there's quite a discrepancy between these numbers here. And all the other minority and racial ethnicities are only constitute 8.9% of the individuals that were able to access PT care after this particular surgical procedure. A further breakdown of it, and we learned that Black individuals, um, there was only 5.2% compared to 12.6% of the general population. And I'm also going to note the Latinx community. Um, so at the time, we were 19.1% of the general population in the US, but only 1% utilized PT services after surgery. There's also a discrepancy, quite a disparity in Asian individuals. So 6.1% of the general population compared to only 1% who received PT after the surgery. And in this bar graph, we see that all underserved minority individuals that received PT were significantly different from the reference point, which is in this case, individuals that are identified as white. Lastly, from the same study, we can see the odds ratio. And the error bars in this graph, what they do is they show the range within which we are very confident that the true population value lies, or the mean. And we are, in this study, 95% confident that the true mean value falls within this range. So even with all of these considerations, we see that an odds ratio of 1 would mean no differences in these groups and the referent, which is white individuals. But when we take a look at this graph, we realize that all of them are under that 1.0 value, which means the exposure is associated with lower odds of the outcome. So, in plain terms, patients who were Black, Native American, Asian, and Latinx were not very likely to receive PT services after the surgery, and that was a significant finding in the study. Health disparities in the US were defined in 1999 by the NIH as the differences in the incidence, prevalence, mortality, and burden of diseases and other adverse health conditions that exist among specific population groups in the US. And typical examples of some of these health outcome disparities include patients who are Black, non-Latinx, but who show less improvement in self-care and mobility after spinal cord injury, inpatient rehab compared to those that are white. Patients who identify as Asians, Black, non-Latinx, and Latinx show poorer outcomes compared to patients who are white, non-Latinx after inpatient rehab for hip replacement surgery. And there are disparities across racial groups of patients in the amount of therapy they receive and the level of intensity in therapy, interventions, and activities that have been observed, even when the functional outcomes are similar. So once we consider these facts, we have to wonder, why is that? Why is there a difference in not only the services that other groups receive, but how can we explain the differences in health outcomes? This is a much larger issue and challenge when it comes to people with disabilities. They are twice more likely to find healthcare provider skills that were inadequate for what they needed, three times more likely to be denied healthcare access, and four times more likely to be treated badly in the healthcare system. And this is particularly quite problematic. In 2013, the Agency for Healthcare Research and Quality provided expanded analysis of people with disabilities, and they defined those individuals as children with special healthcare needs and adults with multiple chronic health conditions to be more inclusive. And the report highlighted worse access and lower quality of care for individuals with disabilities, even when we compare it to those without them. That brings me to the last point in this short presentation about the importance of intersectionality, which is in the context of health disparities, it refers to how these multiple social identities, as you can see here around this infographic, they interact and overlap to create unique experiences of disadvantage and privilege. And all of that impacts a person's health outcome and access to healthcare. I hope you learn a little bit about health disparities and you get excited about what that would mean in physical therapy practice. Thank you.